I've got 10 minutes for a 25-minute presentation, so we might, we'll see how we go. We might run over a tiny bit, but Martine said there's so much in the way of new studies coming out, but they're very complicated, a lot of the studies, and it's difficult for Dr. Chapman and myself to understand. So how is the lay person who is not involved in research or medicine meant to understand them? So she asked me to try and explain them in a lay fashion to let you know about some of the latest breakthroughs in research. So I've got here some of the big journals where they're published in Nature, New England Journal of Medicine, Lancet, Journal of Hepatology. If I manage to get my PhD research in one of those, I'll be a very happy girl. So I'm going to talk briefly about how to look up the articles. So if you're taking notes or look at this on YouTube later, at the bottom of every slide, I'll tell you that in a moment. I'm going to talk about a few studies looking at the cause of PSC, a few looking at ways you can predict prognosis. Some of those merge in with changes in management from the research, as well as probably about 4 or 5 studies on new therapies and the results from that. And there's one study which Martine especially asked me to mention that didn't really fall into any of those categories because it's completely out of this world. And I was privileged enough to hear the main author speak on it 2 days ago at our annual liver conference, and it's amazing, but I've left that for the end. So how do we look up articles? So at the bottom I've put a recent article that Dr. Chapman and I wrote, a review article on PSC. And so you can go to Google Scholar, so you just Google Scholar and you'll find it. And that is a Google engine for literary type things, for research articles. So not just lay people having a blog or a website, so they're proper peer-reviewed articles. And you can just copy and paste the whole title of the paper if you know the title, or you could put a few key words like Chapman and primary sclerosing cholangitis and probably find all of his publications. It'll be a very long results section. Or you can actually, if you know what the journal is, you can look up that journal's website and then in their search engine look for that author or look for some of the keywords in the title. So for example, from the example I've got down there, I've said that it's volume 114, issue 1, and so you can go and look up that actual volume and issue. Or you could go to British Medical Bulletin and search for Williamson and find that article. And I did that today and it was there. You can use Google, but it is a bit more difficult to find the articles compared with Google Scholar. And then ResearchGate is like a Facebook for researchers. And Dr. Chapman and I certainly use and put all of our research articles up on there. And a lot of researchers will actually put their publications on there so that people can access. Because those earlier things, sometimes there's limited access to get the articles. And on ResearchGate, some people sometimes put it. But also, you can message the author and say, may I please have a copy? So whilst they're not allowed to just put it publicly for everyone, they can send you your personal copy. And I certainly do respond to requests from that. And then last of all, if you're looking for what are the new clinical trials in PSC, clinicaltrials.gov, every new therapeutic clinical trial and other clinical trials, not just of new drugs, it's encouraged to go on this. And if you type in primary sclerosing cholangitis, which I did this morning, there were 71 studies there. You can click on that and see what they're about. And you can, a lot of them are in America, North America, etc. But you can find the studies that are in England on that as well. And you cannot study a new drug in any disease without being registered on that. But the problem is when you're doing all of that, you're reading the results, but it's difficult to know whether they're good quality studies or not. And I'm going to show you some studies I don't think are the best quality. I have to be careful because this is all going public on YouTube. But just that if you have a study that you're really interested in, it might be a good idea to print off the abstract and discuss it with your doctor as well, especially with your PSC doctor, who should be up to date with the literature, and if not, you'll enlighten them and they can read it and let you know. Right, so talking about cause first, so I'm going to talk about the gut microbiome. And just to give you an idea, we talk about different families, etc., and there's a kingdom. We're all part of the animal kingdom, as are the microbiota. And then if you go several under, so above species, you have phyla. And you have different phyla of bacteria, PHYLA, and the two main phyla you have in your gut are Firmicutes and Bacteroidetes. So it's similar to saying of Homo sapiens, we have Asians, Latinos, Caucasians, etc. So to the Bacteroides and Firmicutes. And they're the main ones that make up and they're probably the best ones. And then we've got these other ones called Proteobacteria and actinobacteria and a few others. And I think the one that Dr. Chapman mentioned, the Varionella, is one of those smaller ones. And so when we look at the microbiota, we look at different percentage contributions of these 4 main ones, as well as individual ones. And when you look at individual ones within, there's hundreds of thousands within those phyla. So a lot of the research is looking at what relative proportion you have of them. And in general, Firmicutes is probably the best one, and Bacteroidetes is the next one. And here's another plot similar to what Dr. Chapman has shown of a different study. This is called a principal components analysis, which basically means if you took every single person's microbiome and did very, very fancy statistical analysis, you come up with them falling on this plot. And the computer software can put you into different clusters. So in yellow are healthy controls, and in the blue and kind of turquoise are the PSC patients, and in the red are the Crohn's and UC only. And you can see how they've all separated out, much like Dr. Chapman's one. And then you can go in and drill down and find those differences. So it's extremely fancy statistical software, which I'll be using soon, and I struggle to understand. But the statistics does it for you, and you can see the differences. But the one thing I'll say about these gut microbiome is that there's now about 5 or 6 studies in PSC. None of them are very large. The largest is only about 100 patients or so with PSC. They're small studies, and they've all found a distinct microbiome in PSC except for one, and the one that didn't was only about 30 patients. But they all found slightly different things. So it's really hard for us to use that and then go straight to, oh, well, we should all try and get rid of that bug, or we should all enrich our gut with that bug. At the moment, there's still quite a bit more that needs to be done, probably with a collaborative effort to find out what are the good and the bad guys. And then it's all influenced by this FUT2 gene that Dr. Chapman mentioned. So that leads me on to another interaction between the gut and the liver, which this is a paper that came out. So I'm only really looking at things from this year. I think this one just slipped in. It was the end of last year. So this is very akin to what I'm looking at. And it's to do with immune cells in your gut leaving the gut and travelling to the liver, or being diverted to the liver. And there's ways that you can tell that an immune cell or a lymphocyte, what clone it is. So what this group did, it was a collaboration between Norway and Birmingham, is they took lymphocytes or immune cells from the liver and from the gut of the same people, both PSC patients and healthy controls. And then what they did was they looked at one of the receptors on that cell, the T cell receptor, and they sequenced it. A bit like when you sequence someone's DNA, you can sequence and see exactly the signature of that T cell receptor. And a T cell receptor tells that T cell what bad thing it's going to go and attack. There's a specific T cell receptor for different T cells. And what they found is that there was an overlap between the gut and the liver in both situations, but much more so in the PSC patients. It was 9% compared with about 3.6% in control. So there were more overlapping clones of these immune cells between the gut and the liver in PSC compared with healthy controls. Now, there were some problems with the study, which I won't go into now to do with the mechanisms, but it still was more evidence that there probably is a link, and there's a big link that it might be immune cells going from the gut to the liver. And the reason why that's important for everyone with PSC is that it means should we be looking at therapies that target gut-homing immune cells, and that is something that we're looking at. So then this study was another gene study, but it's the first study in PSC to find a gene that actually could predict whether or not you had a bad or a good outcome. And the gene was called R-spondin. So if you think of a cell and you've got your chromosomes, and you take out the DNA, you've got these base pairs in DNA. You might be harking back to your biology days, but you have 4 base pairs: guanine, cytosine, adenine, and thymine, G, C, A, T. And when you have a gene, often you have 2 copies. So you could be that you get from your parents. So 1 G from your mum, 1 G from your dad, 1 A from your mum, 1 G from your dad. So this particular gene, this gene they identified, you could either be GG, AG, or AA. And so they found that if you were AA, you had a worse outcome compared with if you were this other gene. So basically it was to look at, it's called haplotype, what version of the gene you had. And so this is a plot, you've seen a lot of these from Dr. Chapman. Basically over time, what is the likelihood of you surviving, either surviving or surviving without needing a liver transplant. So the lower the curve is, the worse you are off. So one thing is you could test everyone for this gene and see, put you in a prognostic category. It's a possibility, but is limited by how much it costs these days right now. The other thing you could do is you could see what this gene actually does. And this gene is important in bile duct cells as well as specific liver cells that contribute to scarring. And there are ways that you can have gene therapy, which is quite a bit further on at the moment. There's new technology where you can delete and change genes, which is not being done in humans at the moment. It's called CRISPR. It's being done in animals and soon to be done in humans, but potentially we could do gene therapy which could alter the course of the disease. So that's very exciting. So then this study was a huge collaborative efforts of 7,000 patients from North America, Australia, Europe. Many of you in this room would have contributed because UK PSC did contribute to this. And they basically looked at all of the different variables for the patient. So of this 7,000 group of PSC patients, they looked at all the different things and what put you at greater risk of progressing. And it was also to test all of the smaller studies, some of which Dr. Chapman mentioned earlier. And then of all the patients, 7,121 patients, they said, did they get a liver transplant or die? Or did they get a liver or bile duct cancer? And then from that, they looked at all the different little components and what the risk was. So especially things that came out that they were looking at was age at the time you were diagnosed, male or female, whether you had small duct or normal PSC, and whether or not you had inflammatory bowel disease and what type it was. So here's one of those plots again, and the lower down you are, the quickly you either need a liver transplant or die from your PSC. And here, the younger you are, here's less than 20 years and here's greater than 60 years. The younger you are at diagnosis, the better prognosis, and the older, the slightly worse. Second of all, there was a slight advantage to being a woman, but the advantage is very small. Okay, so it's not a massive, not compared with PBC, where there's probably a bigger disparity. There's a slightly increased risk if you're male, but not enough to really make a huge difference. The type of PSC, so the study that Dr. Chapman showed earlier was on several hundred patients. This is on 7,000 patients overall, and very much small duct PSC is a much better prognosis compared with if you have overlap with autoimmune hepatitis or classical PSC. And last of all, the type of bowel disease, they actually weren't able to show that if you didn't have inflammatory bowel disease, you did better. There's some other smaller studies where it was, but it's still not really, really clear cut. But definitely they showed that if the bowel disease you have is Crohn's disease, that you have a slightly better prognosis than ulcerative colitis. So all of these figures I've shown you are for your risk of liver transplant or dying from the liver disease. I haven't shown you the data for developing bile duct cancer, but I think this paper, actually I don't think it is open access, but it was very similar, the same type of risk factors for bile duct cancer. And so the reason why this last study is important is because it can help us risk stratify patients and how aggressive we are with trying new therapies and directing to trials. So another prognostic research study was one that Dr. Chapman and I were involved with, where in Amsterdam they looked at all of their patients with PSC and looked at risk factors for progressing, and then they conducted a statistical calculator using different variables. You put in all the variables, like age and things like that, and it spits out your chance of needing a liver transplant or dying from PSC at 5, 10 and 15 years. And then they tested that calculator in our Oxford cohort here. And so they've made a website which can be found in this paper, and if you've got this unlock signs, it means it's open access, so this paper is available for everyone to read and the website is in there. When you go to the website, it's on the, on the Dutch website, and everything is in Dutch except for Prognostic Calculator, so it's obvious where to go. And so in here you can input your subtype, your various lab values at diagnosis, and you can also use this after you've been on therapy for a while. So you can do this at baseline, but they've looked at it and it can be done later on when you've been on therapy if those have changed. And you have to also put what your reference range is, because as Dr. Chapman said, the ALP reference range or bilirubin or albumin might be slightly different. So you have to change it, and it might be the upper limit of normal or lower limit. So you'll need to find that out to be able to put that in. And then you're given this graph, and it tells you at different years from diagnosis what your % chance is of needing a liver transplant or coming to an untimely end. But basically it gives you a score, and it does this statistically. It's definitely not definite, you know, there's a big range, but it does help risk stratify. And I would suggest that if you were thinking about doing this, that you do it in conjunction with chatting with your GP and especially with your PSC doctor. And you can also write to your doctor, you know, if you've got an appointment ages away and need their advice as well, but it is publicly available. So the reason why this is good is because, again, we can risk stratify patients and potentially patients with higher risk disease we see more often, patients with lower risk we maybe don't see so often, and how aggressive we are with therapy, particularly as new therapies become available. So the next study is looking at FibroScan or elastography, which some of you may have had, as well as the spleen length, and this was one that just came out recently. And this is the second study looking at FibroScan and PSC from the same group in France. So a FibroScan, they put this probe on your skin on the right, and you feel a little vibration, which is a little shear wave going in and reflected back, and it tells us how stiff the liver is. It gives us a number which could be anywhere from 1 or 2 up to the 60s. And the higher the number is, the stiffer the liver is. And the spleen length, so your liver's here on the right, this is all mirror image, your spleen is over on the left, so there's your spleen there, and the spleen enlarges as your liver disease progresses. So they also looked at an ultrasound image of the spleen and what the length was of the spleen and whether that also corresponded with outcome. So first of all, these F1, 0 to F4 are advancing stages of fibrosis or scarring on liver biopsy, and they found the levels, so these horizontal bars, that corresponded with the liver biopsy scarring on the FibroScan. So basically they showed that the FibroScan values corresponded with the scarring on the liver biopsy. And then they looked at cut-off points for the numerical value for the FibroScan. So they looked at 9.9. If you were less than 9.9, you had an extremely good outcome, and if you were greater than 9.9, not so good. But then also, if you used a different cut-off of 18.5 again, you did quite well. And then last of all, the spleen length. If your spleen was less than 12 centimetres or 120 millimetres, you did very well compared with greater than. So this one is one that lots of people have an ultrasound regularly. So yet another way that we can characterise patients. This is one from Palak Trivedi, who did his PhD at Birmingham under Gideon Hirschfield. And this is a very complicated slide, but the main thing I want you to take away is this thing called VAP1, or vascular adhesion protein 1, and it sits on the blood vessel wall in your liver, and it can potentially attract the immune cells into the liver. And so what he found was in the liver, patients had higher activity, higher levels of VAP1 in PSC compared with PBC, normal liver and autoimmune hepatitis. So there was more VAP1 in the liver in PSC, or more activity. He also looked in the blood, because the VAP1 can actually come off and float around in the blood, and he found that there were higher amounts, that red line, higher amounts in PSC compared with controls. He also found that if you had PSC, you had higher levels if you were cirrhotic compared with not having cirrhosis. And finally, he split people into a low VAP1 level and a high VAP1 level, and he looked at outcomes in terms of needing liver transplant or dying from liver disease. And if you had a low serum VAP1 level, you had a much better prognosis. So bringing that all together, it could be a prognostic marker. Oxford and London are involved with trying to validate that research to show in our cohort in London. And many of you have given an extra blood test when you've come and seen me at clinic, and that's what this blood test is going to. And then in addition, we may be able to target VAP1 and try and block VAP1 because we think that VAP1 probably promotes scarring. And also recruiting the immune cells. And that's a trial that we have going on here, which I'll talk about soon. How am I going? I think what people do want to hear about this. So this is an old study, but for me to then show you the new study. This is they've looked at the liver of mice who have received norosodiazoxycholic acid or who haven't. This is a healthy mouse. That's the bile duct there. This is a mouse that has PSC, or a similar version of PSC. And you can see that this bile duct here suddenly has got all of this funny stuff around scar tissue and inflammation. Then they gave the mouse urso, and it's a little bit better, but it's still got scar tissue there. And then they gave it Norurso, and it completely disappeared. Okay, so it's amazing results to go from that to that. This red mark is a specific scar tissue mark, and you can see there's a lot less red here than there is there. So this was very exciting back in 2006. So then they did the study in humans, and we did this with 8 patients here in Oxford, but it was around Europe. And patients either got a placebo or 3 different doses of norursodeoxycholic acid. Now this is a bile acid that's just ever so slightly different from ursodeoxycholic acid, and it's a tablet that you take, and the main aim was to see if the alkaline phosphatase went down. And so in the placebo group, it actually went up a little bit, and in the increasing doses of Norurso, the ALP went down to up to 26% in the highest group, and that was after about 6 months. And then if you look at the trajectory of the ALP over time, this is the placebo and these are the 3 doses, you can see it went down and stayed down until this last point when people came off, and then it came back up. So we think it does do something. There's a modest effect, and it's now moving into a phase 3 trial, which is yet to start. Simtuzumab is a Gilead study that some of you may or may not have been aware of or been in, and it's an injection into the fat that is against an enzyme which has an involvement in forming scar tissue. And so the drug was aimed to try and prevent scarring or reverse scarring. And so they had 234 patients across Europe and I think potentially North America as well. 2/3 received the drug and 1/3 didn't. And it lasted a long time. It lasted, almost 2 years. And the primary endpoint, the main thing they were looking at was changes in the amount of scar tissue. They did a liver biopsy at the start and at the end. And the results were they found no change in the amount of scar tissue, no change in the alkaline phosphatase. They did find the drug was safe and well tolerated, but it just didn't do anything. So overall it was a negative study. Having said that, they got a lot of other information that's been useful for learning about the natural progression of PSC, but this drug is not going to be used in PSC, and it's being developed now for fatty liver disease. Vancomycin, a lot of people have asked about, and certainly did at last year's talk. And there was a small Iranian study published recently of 29 patients with PSC, and they gave 2/3 vancomycin, which is an antibiotic, and 11 they gave placebo, all with PSC. And they also still had their treatment with urso. And the main thing they looked at was the alkaline phosphatase at the start and the end. They kept changing their mind a bit about what the primary endpoint, and it was a slightly confusing paper to read. But the main outcome, these are the vancomycin patients at the start, at month 1 and at month 3. And they said there was a difference between these two, month 1 and month 3, but not a difference between the baseline and month 3, which is to do with statistics and to do with how wide the range was at the start. So basically, they said it was a positive study, that there was a change. Really, it was a negative study because there wasn't a change from baseline to month 3, but that may be a fault of the design of the study, the amount of patients. And so I think that this gives a little bit of promise, but it needs a bigger study. And there is a study going on in children and past ones in children with some merit. But I will say it's not enough for us to be treating everyone with vancomycin. Apart from being expensive, it does have side effects, and it can also breed bacterial resistance for people if they get cholangitis, so you've got less antibiotics that you could use if you ever develop it. So I think vancomycin is a watch this space at the moment. So then reflexmin, I don't know if anyone's heard of reflexmin. It's a special type of antibiotic which is non-absorbable. So other antibiotics, when you swallow them, get absorbed by your gut, go to the bloodstream and have their antibacterial effects everywhere. Whereas reflexmin is something that it doesn't get absorbed, it only has its antibacterial effects on things that are actually in the gut. And it's been licensed for hepatic encephalopathy, which is a brain condition that people can get in advanced liver disease. But the theory was, if there's problems with the bacterial composition in PSC, could you try and treat the bacteria with this drug with minimal side effects? So they tried this with 16 patients. It was open label, so there's no placebo. They just gave it to everyone to see what it would do. And unfortunately, there was no change in the ALP. Whether or not that is the main thing they should have looked at, whether 3 months is long enough is hard to say. They did also look at symptoms, and it didn't change patients' symptoms or quality of life. And also they had half of the patients had adverse events from the drug. So in the end, it wasn't promising. Whether or not it's looked at in the future is probably unlikely. but just to show that different antibiotics are being trialled. And it is possible to do a small study. And this is exactly how URSO started, a small study like this as well. So then the last one's this out of this world one, and you can see how many people are on this paper, a huge amount. This is from Cambridge, and I think collaborations with various other places. And the title is very confusing. Reconstructions are obvious, you're making something again. Mouse, extrahepatic means bile ducts outside of the liver. So instead of the intrahepatic ones in the liver, it's the ones outside the liver. Biliary tree is just all the bile ducts. Primary means that the cells they're getting come from humans themselves. And then cholangiocytes are the cells that are inside the bile ducts. They're what line the bile ducts. So, and then organoids. An organoid is an artificially grown mass of cells or tissue that resembles an organ. So in other words, the title of this slide is that they've been able to make bile ducts from humans and put them into a mouse, and they can resemble a normal bile duct. So I'll go through how they did that. First of all, there's two ways that they looked at doing it. They haven't mentioned this one. This is an earlier paper they did. You can take a skin biopsy and take the cells, and you can isolate what's called the stem cells, which are like the fetal cells, which can have the ability to go into any type of cell. They could go into a blood cell, a fibrotic cell, a muscle cell or a heart cell. You can change those to become whatever cells you want by very difficult ways to work out, but they worked out how to make them into cholangiocytes. But then they said, why do all of this? They actually found that if they actually just took cholangiocytes from a human, either from ERCP or from a gallbladder when it's removed, or even from people when they had a transplant, they just took some cells from the bile duct of the liver that was removed, and they took those cells and they did various things, and they could make them go into a layer of cells that then were active. So cells don't just sit there. They actually secrete enzymes, and they absorb and make bile, and bile goes in and out of it, and they showed that they could make the cholangiocytes do all those sorts of things in the dish. So once they'd put them in the dish, they went and got a scaffold with their engineering team, a little tubular structure, and they put the cells on that scaffold. And those scaffolds took, those cells went on the scaffold and they grew around it in a tubular structure. And then what they did was they did some little surgery on the mouse under an anaesthetic. Here's the mouse's bile duct. They took a bit of their bile duct out. They put the luminal, the cylindrical structure they'd made of cholangiocytes in, and there it is there. And here, I don't know if we can turn the lights down a little bit for a sec. Here is the actual thing in the mouse. So here's its proximal bile duct and its distal bile duct, and that is the structure they've sutured in, the scaffold. And when they looked at it, that's what it looked like, but they put a fluorescent dye through it and they show that it flushed through just like normal bile. But then they had a dummy one which had different cells on the scaffold and it didn't work. So you have to have functioning cholangiocytes. So that's a lot of information taken, but basically they have engineered a human bile duct, which is huge. I mean, it's like creating a new organ, and I've never seen anything like this before. So we can probably turn the lights up again. In the first instance, the main thing that it will be used for is that when they're in the dish, you can test drugs on them, see what the drugs do. So you could put Urso onto the cholangiocytes and see what it does. You can put vedolizumab, you can put, simtuzumab, all different drugs that you're going to try and see what it does to the cholangiocytes before you start testing it in humans. And it's a proper functioning bile duct cells. And then the second thing is, who knows, one day you might be able to cut out that diseased bile duct and put in one of these. But that's a long way off, but it is very exciting. So in summary, there's been a big increase in PSC research in recent years, a huge increase. There's new clues about the cause to do with overlapping immune cells between the gut and the liver, as well as particular genes driving the disease. We've got improved predictors of prognosis, such as the FibroScan and spleen length, and this risk score that any patient or doctor can use. There's new therapeutic agents emerging. I know that I presented quite a few negative studies today, but that's because I was only presenting the published work. There's a lot more new trials going on. I'll mention some of them in the next talk briefly. But I think it's important that you know what's also being tried and hasn't worked as well and how it's gone about it. And then there's huge scientific breakthrough like this Cambridge study. And that's all I have to say on the latest literature.